Hello, Assalamu alaikum. I'm Dr. Beenish, and all can hear me?
Yes, we can hear you.
Okay, so we are starting our presentation now. I am Dr. Beenish. I am from Pakistan, Karachi. I did my MBBS from Dow and my MCPS from Pakistan and MRCOG from UK. So our topic for presentation today is a good obstetric history and physical examination. Most probably this is the first thing that we are learning when we are coming in the field of obstetrics and gynae, but we are doing it today with the clinical perspective and how we are using it, because these are the cornerstones of a successful outcome. So the significance of good obstetric history is insight into the status and complication of a patient's current and previous pregnancies can aid in the early diagnosis and management of any issues that may arise. History often repeats itself, so previous antenatal, intrapartum, or postpartum complications should influence the management of the current pregnancy. Involvement of multidisciplinary team as needed. Taking a history and performing obstetric examination are different compared with the history and examination in other specialties, because the main difference is that the patient is normally a healthy woman undergoing a normal life event. Although antenatal care is designed to support this normal physiological process and to detect early signs of complications. The type of questions that we ask during the history and are changed according to the gestation and according to the purpose and the nature of examination. The history usually covers the physiology and the pathology that happens in the pregnancy. An obstetric history include biodata like name, age, occupation, address, relationship status, record number, etc. Current pregnancy details, past obstetric history, past gynae history, past medical and surgical history, drug history, and allergies. Social history including drug use, domestic violence, psychiatric illness, especially in the postnatal period, and the family history, especially with regard to multiple pregnancy, diabetes, hypertension, and congenital malformations. This is just a brief layout, and we will talk about it in detail. Regarding the biodata, since all we know that this is just to make sure the notes are not intermingled with other patients, the occupation just to make sure it is not hazardous during the pregnancy, and address so that we can make an idea that the healthcare is available to that woman in the nearby facilities. Relationship status, as we all know, single motherhood is always challenging, and record number so that it can be make out. Talking about the current pregnancy, it's very vital to make sure of the gravidity and parity. Gravida, as we all know, number of the pregnancies, including the current one, and parity is the number of births beyond 24 weeks gestation. But there are some miscarriages and termination that do occur before 24 weeks. So we will write it as gravida X para A plus B. So para A are those who are completed 24 weeks, and plus B are those who are before 24 weeks. Like if the woman is pregnant for the fourth time, she's gravida 4. If she has given one birth vaginally at term, she's para 1. But she had 2 miscarriages, so it is para 1 plus 2. What is the significance of this? Grand multiparity is a high risk for adverse maternal outcomes during pregnancy and childbirth. These adverse maternal outcomes include postpartum hemorrhage and malpresentation. So this is the clinical perspective of this image. Talking about the LMP and EDD is very important. We all use maybe the obstetric wheel. Nowadays, the smartphones, they do have the applications to calculate it. We take ask the LMP from the patient, and we do it either with this wheel or some smart app, or calculating it by adding by add 1 year and 7 days to the LMP and subtract 3 months. Some people prefer to add 9 months and adding 7 days. Although when we are doing it, we have to make sure about the cycles of the patient, because if the patient is cycles are not regular, patient was using some contraceptive pills, then the LMP may not be very accurate. So the EDD will not be accurate as well. In those scenarios, it is recommended to do the dating scans between 8 and 13 weeks, which are more reliable than the LMP. And if it is done, they should be used to provide an EDD where possible. The significance of this, it is help to track the fetal growth and planning about appropriate delivery time frame, so that we are knowing that at this gestation, the fetus should be at this weight, the fundal height should be at this limit. So it is very important to ascertain about the LMP and EDD. Current pregnancy details are also very important to make sure of the woman's current health status. If more than 20 weeks, inquire about fetal movements, general health, general details of pregnancy to date, if she is doing well, if she had any previous admission, any current problems, she had done any antenatal blood tests, routines and specific, any scans she had done, and then we can correlate the scans and we can carry on the antenatal care from that point. If she is postnatal, we usually ask about the labor and delivery and history of the postnatal period. In that, we ask about the 5 Bs, like if she is voiding normally, if she has opened the bowel, the pervaginal bleeding is okay, she's breastfeeding the baby, and how the baby is doing. Talking about the past obstetric history, this is the element of the obstetric history which is very much significant in deciding about the management of the current pregnancy, because history tends to repeat itself. It is one of the important areas for establishing risk in the current pregnancy. Like for past obstetric history, we ask about details of all previous pregnancies, length of gestation, onset of labor, including details of induction of labor, date, place, and mode of delivery and puerperium, neonatal sex and birth weight and neonatal life. Clear details of any complications or adverse outcomes such as shoulder dystocia, postpartum hemorrhage, or stillbirth. So what is the clinical significance of this asking post-obstetric history? As I told you that history tends to repeat itself. So if there is a history of recurrent miscarriage, so still there is increased risk of miscarriage and fetal growth restriction. Preterm delivery. So there is increased chances of preterm delivery. Early onset preeclampsia, then still there is a chances of preeclampsia and fetal growth restriction. If there is history of abruption, so it's still there's increased risk of recurrence, congenital anomaly, macrosomic baby, fetal growth restriction, they have all increased recurrence. Unexplained stillbirth, one of the most dreadful thing, increased risk of stillbirth is still there, and maybe there was history of undiagnosed gestational diabetes. So other than that, if even everything is normal, the method of delivery for any previous birth must be recorded, as this can have implications for planning in the current pregnancy, particularly if there has been a previous cesarean section, difficult vaginal delivery, postpartum hemorrhage, or significant perineal trauma. This will help us to plan the mode of delivery in the current pregnancy. Regarding the past gynecological history, method of contraception, menstrual cycle history, history of PID or any infections, cervical hair, smear history, or any relevant treatment like LEDs or knife cone biopsy. Previous gynecological procedures like cystectomy and myomectomy. These are all to be asked, and how they are impacting our current pregnancy. So let's talk about it. The significance is that if the cycles are irregular, if the patient was using any contraception like OCPs, injections, it will all affect the cycles. So the LMP is not the sure one, so as the EDD. If she is pregnant with IUD in situ, she's at risk of miscarriage and preterm labor. If there's a history of pelvic inflammatory disease, so there's increased risk of ectopic pregnancy, so early scan is recommended. In terms of cervical smear, if we talk about cervical cancer, the late diagnosis is more common around the time of pregnancy because smears are deferred. If a smear is due, it can be taken in the first trimester. It is important to record that the woman is pregnant, as the cells can be difficult to assess without this knowledge. That's why if we are taking the smear in the pregnancy, we are always mentioning it that the patient is pregnant. So the histopathologist is aware of this and they will look into the sample with this detail in mind. If there is history of any treatment like knife wound biopsy, it is associated with increased risk for both cervical incompetence and stenosis, leading to the preterm delivery and distortion in labor respectively. There is probably a very small increased risk of preterm birth associated with LEDs. However, women who have needed more than one excision are more likely to have much shorter cervix, which does increase the risk for second and early third trimester delivery and may need cervical cerclage. Multiple previous first trimester surgical terminations of pregnancy potentially increase the risk of preterm delivery, possibly secondary to cervical weakness. Pelvic masses such as ovarian cysts and fibroids and related operations. They do have impact on delivery because sometimes they possess an obstruction for the presenting part and may also pose some problems during pregnancy and help in delivery planning. Like if the myomectomy has been done and the uterine cavity has been opened, so it is recommended to do a cesarean section for that woman. So it helps in the delivery planning as well. Talking about the medical history and its significance, this list is not the complete list, but it does mention the main systems that we are worried for, and it does have a great impact on the current pregnancy. Like some pre-existing disease that have impact on pregnancy are like diabetes. It can lead to macrosomia, fetal growth restriction, congenital anomalies, preeclampsia, stillbirth, and neonatal hypoglycemia. If the patient has hypertension before, she has an increased risk of preeclampsia and the worsening hypertension. For the renal disease can be worsened. She can develop preeclampsia, fetal growth restriction, and preterm delivery. Epilepsy, there's increased fit frequency and congenital anomaly. If she has venous thromboembolic disease or any history of venous thromboembolism, she has increased risk during pregnancy. If associated thrombophilia, increased risk of thromboembolism and possible increased risk of preeclampsia and FGR. If she is HIV positive, the risk of mother to child transfer if untreated. If she has any connective tissue disease like SLE, then she has increased risk of preeclampsia and FGR. Some other complications that may happen with some myotonic dystrophy and myasthenia gravis are fetal neurological defects and increased maternal and muscular fatigue in labor. It is very important to make notes of any pre-existing medical illness in the patient so that appropriate referral and the MDT help can be taken. We can arrange some referral to our colleagues in different specialties like visit to an endocrinologist, a visit to a physician to help managing diabetes, hypertension, and the renal disease, etc. Making sure of the past surgical history is very important because it does have some significance in the pregnancy. Like if the surgery has been performed for conditions that may continue to be a problem during pregnancy, such as Crohn's disease, because this is a remitting relapsing condition, it may exaggerate in the pregnancy as well. The surgery may be associated with scar tissue formation, so it can help to gauge surgical difficulty in case cesarean section is needed. Family history is important. It is important to ask both parents. It is important to know about any family history of babies with congenital abnormality, genetic disorders, and any potential genetic problems such as hemoglobinopathies. Important areas are a maternal history of a first degree relative, sibling or parent with diabetes, thromboembolic disease, preeclampsia, and serious psychiatric disorder. Because if she does have this history in the family, she herself is at increased risk of these complications. Cousin marriages. It's very common in Pakistan. There is increased risk of complications with the fetus. So we have to make sure that the appropriate counseling and screening is offered because it has implications for the fetus and on the mother herself. Social history, we ask about smoking, drug, alcohol use, plans for breastfeeding, some social aspects like plans for childcare arrangements, and domestic violence screening. These are very sensitive topics and should be asked very sensitively. Smoking, drugs, they do have impact and they can cause miscarriages, growth restriction, preterm birth, and stillbirth and neonatal death. Alcohol, it can cause fetal anomalies like fetal alcohol syndrome. If the patient says positive about it, so we have to guide her about the cessation techniques, and we can take help from colleagues to help them to quit these habits. Domestic abuse, a very, very sensitive issue in Pakistan. There are constantly changing laws about it, and there is emerging awareness about it. So we have to screen it. And maybe pregnancy is the only time that the woman can come across with some doctor or she can get some help. So it's very important to talk to the woman at least once alone in during 9 months so that she can be open, and she should be make sure of it that help can be given to her. So if she says positive about domestic abuse, that there's a history of domestic abuse, so pass on to the relevant team. In UK, there are teams which are dedicated for this purpose. In Pakistan, we definitely we have to look in our own areas that what teams are available, what support is available for the domestic abuse patient. At least the patient can be guided the safe limits if the partner is carrying some weapons, or if in the life is at severe threat, then she can be guided for security. To ensure adequate counseling and screening is offered, to arrange maximum possible support. These are the significance for the social history. Drug history is important because we ask about current medications and medications taken at any time during the pregnancy. Because some medications need to be changed in pregnancy according to safety, and some medications need to be continued, like anti-epileptic medications. So the drug history is very important and should be guided accordingly. Folate supplementation is also necessary, so we have to ask about it. Allergy history, any allergies and their severity, if that cause anaphylaxis or a rash. If a woman gives a history of allergy, it's important to ask about how this was diagnosed and what sort of problem it causes, so that we can be careful in prescribing medications to her and can make appropriate planning. If some women are allergic to iodine or latex, then we can take care in the surgery. If some medications are harmful to her, we will not be prescribing those medication to the woman. Mental health history. This very less importance has been given in this aspect, but this is the emerging condition, and in all over the world, mental health is really important, especially during these times. So we have to ask about whether is there any recent changes in her thoughts, or does she feel down, depressed, hopeless in last 4 weeks. If she says so, we have to probe that what are the issues, why she is feeling that, and what help can be offered. Because suicide, homicide, these are really dreadful during the pregnancy, especially under the effects of the hormones. Women with significant psychiatric problems should be cared by a multidisciplinary team, including the midwife, GP, hospital consultant, and psychiatric team. This is just a short briefing that we have just discussed so far, just a short template. Talking about obstetric examination, always introduce yourself and say who you are. Make sure you are wearing your identity badge so that the patient may feel more confident. Wash your hands or use alcohol gel. Be courteous and gentle. Always ensure the patient is comfortable and warm. Always have a chaperone present when you examine patients. Tailor your history and examination to find the key information you need and adapt to new findings as you go along. It means if you have reached to some complication in the previous examination, so try to correlate the current examination with that examination, and try to correlate your examination with your current history and the findings. Present it in a clear way to the patient as well. Be aware of giving sensitive information in a public setting. Like some people, if they are married, they are doing a second marriage, sometimes they are not telling in the family, but they can tell to the doctor that she had the previous marriage, she had kids with that marriage, she had miscarriage with that marriage, at least so that we can make the plan accordingly. The examination should be directed at the presenting problem, if any, and the gestation. For instance, it is generally unnecessary to spend time defining the presentation at 24 weeks gestation unless the presenting problem is threatened preterm labor. Some general examination which has impact in the pregnancy management, like BMI. BMI, if less than 18.5 or more than 25, it is associated with complications of lower BMI and higher BMI. With lower BMI, for instance, at increased risk of fetal growth restriction. Obesity itself is a challenging condition to be managed in pregnancy because of weight gain during the pregnancy, as well as for doing the scans and for the delivery planning. We have to see for the pillar, edema, jaundice, and enlarged lymph nodes, which can point out if the patient is having anemia, hepatitis, or some other conditions. Measuring blood pressure is very, very important in pregnancy. 140/90 we can take as a guide to be alarmed. If BP is 140/90 and above, then we should look for the cause. What can be the cause? So appropriate technique, appropriate size curve is important. In previous lectures, I have seen the normal physiological changes have been discussed. So still, just a quick revision, heart rate does increase in pregnancy, blood pressure decreases in the first and second trimester, and then it becomes to the normal or a little bit higher in the third trimester. Auscultation of the heart and lungs are important because flow murmurs are common in pregnancy and are not significant, although cardiac murmurs may be detected for the first time in pregnancy. Respiratory rate, it remains unchanged. Thyroid gland, sclera goiter, breast, although routine examinations are not recommended, but the self-examination to be discussed with the patient and exclude any lumps. Varicose vein and skeletal abnormalities in normal pregnancy is associated with an increase in lumbar lordosis, which can lead to lower backache. Abdominal inspection. Assess the shape of the uterus and note any asymmetry. Look for the fetal movements. Note any signs of pregnancy, such as stria gravitarum or linea nigra. Look for scars. The common areas to find scars are suprapubic, which can signify she had previous history of cesarean section or a laparotomy for ectopic pregnancy or ovarian masses. Subumbilical, there can be history of laparoscopy. Right iliac fossa, there can be history of appendicectomy. Right upper quadrant, there can be history of cholecystectomy. Talking about the abdominal palpation. Asking the patient to comment on any tenderness and observe her facial and verbal response throughout and note any guarding. For palpation, symphysiofundal height measurement is a very important aspect of obstetric examination to track the fetal growth. Feel carefully for the top of the fundus and for the upper border of the symphysis pubis and measure the symphysiofundal height in centimeters. The mean fundal height measures approximately 20 centimeter at 20 weeks and increases by 1 centimeter per week, so that at 36 weeks, the fundal height should be approximately 36 centimeter. After this age, there can be error of plus minus 2 centimeter, plus minus 3 centimeter, because the fetus dips down in the pelvis in the view of upcoming labor. So the fetus descends in the pelvis. Then after measuring this, we plot it on a growth chart. In Pakistan, WHO growth charts are available. What is customized growth chart? A customized growth chart is a one which take care of the physiological variables like maternal height, weight, ethnic origin, and parity. They correlate it, they arrange it, and then it is measured on the chart, and excluding some pathological factors such as smoking and diabetes. They are more sensitive and specific, and serial measurements are of greater value in detecting growth trends than one-off measurements. I will show you an example of this one. So this is a growth chart. You can see on the top left corner, there are mother details like she's para 0, British European, height, weight, and the BMI. So this all has been substituted in this graph. So this graph is customized for that woman, for that ethnicity. Then we are plotting the symphysiofundal height and we are measuring it according to the gestation. We are following two lines on this graph. The above line is 90th centile and the lower line is 10th centile. If the marks are coming as shown in this picture in between 90th centile and the 10th centile, the growth is appropriate. If the growth is coming more than 90th centile, the fetus is large for the gestational age and we have to look for the causes that I'll be discussing. And if the growth is coming below the 10th centile, then the fetus is growth restricted and we have to look for the causes. So but we have talked about how to measure the symphysiofundal height. Some people are using the finger method and it is prone to errors. So the recommended one is to use the measuring tape and use it a customized growth chart. If it is not available, the WHO growth chart can be used. Then talking about some further examination, we have to make sure after the growth that how the fetus is lying in the mother's womb. So for that, the Leopold's maneuvers are used. In that, there are 4 maneuvers and we make sure how the baby is inside the womb. The first one is a fundal grip, and with that, as you can see in the picture in the first one, that we can make sure of the lie and the presentation. If we can feel the soft part at the fundus, it is a breech. And if we can feel the ball shape, palatable mass in the fundus, then it is breech, like the head is at the fundal region. Then the second one is the lateral grip, the picture shown as B, in which we move our hands to the lateral side of the uterus. We try to ballot the baby from one hand. We just make a gentle pressure from the one hand and feel from the other hand. And then we will do it in a reverse manner. From the other hand, we will push and will feel from the first hand. So if we can feel back that it is smooth, broad, regular curved structure, or if we feel a small knob-like structure, then those are the limbs. If the back is left, then the denominator is left occiput anterior, left occiput transverse, and left occiput posterior. What is the denominator? It is one of the prominent part on the presenting part so that we can correlate the position of the fetus. If back is right, then denominator is right occiput anterior, right occiput transverse, or right occiput posterior. Although it seems much here, but this helps an obstetrician to make a delivery planning, because some positions are not favorable for the vaginal delivery and some positions are associated with prolonged labor and may necessitate the use of instrumental delivery. The third maneuver, as depicted in the picture as C, is a polygrip. In this, we make sure whether the presenting part is breech or the cephalic. This finding will be opposite to the finding that we got from the first maneuver, the fundal grip. If at the fundus we found the buttocks, the soft part, then in third grip, the picture C, we should find the head, the cephalic presentation. Or if we find at the fundus the breech, then the C should be cephalic one. Or if we found the cephalic presentation at the fundal area, then there should be soft part at the pollic grip, which signifies that this is a breech presentation. The fourth maneuver is deep pelvic grip. In this maneuver, we have to face towards the leg of the patient and we have to see if the head is engaged or not and what is the attitude of the fetus head. So what is engagement? When the broadest diameter of the fetal presenting part, like in this case head, is dipped down enough in the pelvis that it is at the level of 2/5 grip, then the head is called engage. And attitude, if the head is flexed or extended, it can help an obstetrician to make sure about the delivery plannings. This is all about the technique that I have already discussed. This is about the fetal head descent that we measure and the palpation of fetal head to assess engagement. When the fetal head is 2/5 palpable, we just make this imagination in our mind that if there are 5 parts like this in the fetal head, and like in the fourth picture, it is showing only 2 can be found above the pelvic bone 1 and 2. This head is an engaged head. Just a quick review. Denominator, the name giving to part of the presentation which is used to determine the position of the fetus. Engagement, when the widest presenting transverse diameter has passed through the brim of the pelvis. Flexion, the fetus is curled up with chin tightly on chest, arms and legs flexed. So what is the significance of palpation? The purpose of palpating the pregnant abdomen is to assess the number of the babies. If we find multiple poles, then this is a multiple pregnancy, which has its own complications and need a tailored antenatal planning program for that woman. The size of the baby, if the symphysiofundal height is appropriate or not, the lie of the baby, the presentation of the baby, whether the baby is engaged. A large symphysiofundal height raises a possibility of a multiple pregnancy, a macrosomic baby, or a polyhydramnios. A small symphysiofundal height raises the possibility of fetal growth restriction and oligohydramnios. If we come across these findings on palpation, then we do confirm it with scans and with history and make appropriate tests for that woman. Talk about the auscultation of the fetal heart. This is the aspect I like the most always, because this is always reassuring for the patient, and mothers always enjoys listening to the fetal heartbeat. The Doppler ultrasound device Sonicate can be used after 12 weeks, and the Pinard or a fetal stethoscope from about 24 weeks gestation can be used to make sure that the fetus is doing good inside mother's womb. It should be measured over 1 minute. It should be between 110 to 160 beats per minute when the fetus is more than 24 weeks. In a breech presentation, it is often heard at or above the level of the maternal umbilicus, as shown in the picture above. The NICE guidelines raise the need for routine fetal heart rate auscultation in the presence of fetal movement, but mother enjoys listening to the fetal heart. What are the aims for abdominal examination? Symphysiofundal height to assess fetal growth like SGA and large for gestational age or LGA. It can be palpated when the fetus is less than 20 weeks. It can be measured in centimeters when the fetus is more than 20 weeks. Estimation of number of fetuses like multiple fetal folds, multiple pregnancies or high risk pregnancy and need a tailored plan. Fetal lie, relationship of a longitudinal axis of a fetus to that of the uterus, because if the fetal lie is not appropriate, then we can make a planning. Does she need a cesarean section? Like if it is longitudinal, fetal head or breech palpable over pelvic inlet. Oblique, the head or breech is palpable in one of the fossa and nothing felt in the lower uterus. Transfer, fetal pose felt in flanks and nothing above the brim. Presentation, the part of the fetus overlying the pelvic brim. Again, does she need a repeat scan? Some maneuvers to make it a cephalic version, or a cesarean section is needed. Like, if this is cephalic, this could be vertex, face, or brow presentations, and this can be determined more accurately on vaginal examination. If it is a breech presentation or others like shoulder and compound, with amniotic fluid volume assessment, we can make whether the patient is having polyhydramnios. When we feel tense abdomen with fetal parts not easily palpated in the maneuvers that I have discussed. If this is the case, is she at risk of cord prolapse? Then we can make the tailored plan for that patient, that what measures can be done in view of avoiding the risk of cord prolapse, and make appropriate planning to help this patient to deliver safely, and the complications associated with polyhydramnios like postpartum hemorrhage in the puerperium period. If the liquor is less, a condition called oligohydramnios, then we can feel compact abdomen with fetal parts easily palpable. So we have to look for the causes. There can be any maternal, fetal, and placental causes, and we can do further scans to make sure of it, and further tests to look into the cause, and management would be accordingly. So in short, the history and abdominal examination is done to make sure the current health, the future planning, for the upcoming pregnancy and the delivery planning, and after delivery, what other measures are required to help the woman to recover early and to prevent any puerperal complications. Pelvic examination. Routine pelvic examination during antenatal visits is not necessary. However, there are circumstances in which a vaginal examination is necessary. In most cases, a speculum examination is all that is needed. These include excessive or offensive vaginal discharge, then you will examine the patient. Vaginal bleeding in the known absence of placenta previa is still, if the scan is not there and the patient is bleeding, the speculum examination is safe to do so, although we have to look the general status of the patient. To perform a cervical smear, we can do the pelvic examination to confirm potential rupture of membranes and to confirm and assess the extent of female genital mutilation in women who have been subjected to this. Digital examination may be performed when an assessment of the cervix is required. This can provide information about the consistency and effacement of the cervix that is not obtainable from a speculum examination. There are contraindications to digital examination like known placenta previa or vaginal bleeding when the placental site is unknown and the presenting part is unengaged. It means there must be some problem if the presenting part is not engaged and we have no scan. So the digital examination should not be done, because if this is a placenta previa, there would be a torrential bleeding that may hamper the woman's life itself. Pre-labor rupture of membranes, because there, if the digital examination is there, there are increased risk of ascending infection. This is just a brief of digital examination because it is not routinely recommended in the antenatal examination, although when the patient comes in labor, there are further details of digital examination that would be discussed in upcoming lectures. Other aspects of examination are reflexes. In women with suspected preeclampsia, the reflexes should be assessed. These are most easily checked at the ankle. Clonus. The presence of more than 3 beats of clonus is pathological. So we will read more about it in hypertensive disorders of the pregnancy. Edema of the extremities affects 80% of term pregnancies and is not a good indicator for preeclampsia as it is so common. However, the presence of non-dependent edema such as facial edema should be noted. In conclusion, it is important to ask about a woman's current and previous history and examination, as this may help in assessment of risk in the current pregnancy and have implications for the mode of delivery. Timely management and appropriate referral is the key to successful pregnancy outcome. It means that once we diagnose some problem, appropriate management has been given. If it is not working, we can escalate the care. We can refer the patient to the colleagues who are more expert in dealing such condition. Even if it is a medical disorder, we can take appropriate referral. If the condition is beyond the management facilities of a facility in which the patient is attending, like primary healthcare services, so we can refer the patient to the tertiary healthcare services or the bigger hospitals or the hospitals in the city that can appropriately manage the patient. And we have to arrange the safe transfer of the patient as well, so that women can deliver successfully and enjoy the motherhood. Thank you. I would like to recite one of the Quran verses. Whoever saves the life of one person, it shall be as if he had saved the life of all mankind. Thank you so much.
Thank you very much, Dr. Beenish. That was a lovely presentation, and I really like the way you explained the clinical significance of each and every step in the history and clinical examination. I hope the people who will listen to your lecture, they will benefit from it.
Thank you so much. Jazakallah khair.